Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 354 of our pharmacotherapy series, which majors in asthma. My first question to you applies to patient SHT from case 353 of this pharmacotherapy series. SHT was given one dose of 60 mg of methylprednisolone, marketed as Solumedrol, IV, and 3 doses of albuterol 5 mg co-formulated with ipratropium 0.5 mg by nebulizer every 20 minutes in the emergency department. SHT claimed slight subjective improvement after this therapy. Yet, expiratory wheezes still were audible, and he still was using his accessory muscles for ventilatory efforts. His peak expiratory flow improved only to 35% of predicted, and a repeat ABG measurement showed a partial pressure of carbon dioxide in arterial blood of 40 mm of mercury. So my question to you reads, what should be done at this time? SHT still is significantly obstructed despite intensive therapy in the accident and emergency department. As a result, he should be admitted to the intensive care unit, where he can be monitored closely. My next question to you reads, what would be the best method of assessing the adequacy of therapy in SHT? What are the signs of impending respiratory failure? When patients continually must expand their chest wall with high lung volumes for a prolonged period, respiratory muscle fatigue may ensue, resulting in a decreased ventilatory effort. Clinical signs of impending respiratory failure include increased heart rate, decreased breath sounds, agitation from worsening hypoxia, or lethargy from increased carbon dioxide retention. These clinical signs and symptoms are relatively nonspecific and are affected by many variables. Thus, they should not be used to detect impending respiratory failure. The best way to assess therapy is to monitor ABGs. The arterial oxygen pressure component of an ABG determination is not very helpful because of mismatching and the administration of oxygen. The partial pressure of carbon dioxide is the best indicator of hypoventilation in acute asthma 1. However, there is no single value for partial pressure of carbon dioxide that indicates impending respiratory failure, because different partial pressure of carbon dioxide values are acceptable under different clinical circumstances. A partial pressure of carbon dioxide of 55 mm of mercury 1 to 2 hours after intensive bronchodilator therapy, or an increase in partial pressure of carbon dioxide of 5 to 10 mm of mercury per hour during aggressive therapy is an ominous sign. The fact that SHT's partial pressure of carbon dioxide is not rising with therapy is a good sign. SHT initially received 3 doses of albuterol 5 mg co-formulated with ipratropium 0.5 mg by nebulizer every 20 minutes in the accident and emergency department. He has also received IV methylprednisolone 60 mg. So my next question to you is, would the IV administration of a beta agonist be indicated in SHT at this time? What are other potential therapies in SHT? Although the use of IV beta agonists for asthmatic patients in the ICU formerly was advocated, current standards of care discourage the use of these agents. SHT's response to inhaled albuterol also suggests that IV beta agonists are inappropriate at this time. Because standard therapies already administered were not sufficient, IV magnesium sulfate may benefit severely ill patients like SHT. Recent research suggests that nebulized isotonic magnesium sulfate is a valuable adjunctive therapy to inhaled albuterol in the treatment of severe asthma exacerbations. Further, HeliX, which is a mixture of helium and oxygen, may also add benefit. Intravenous theophylline is being considered for SHT. So my question to you reads, is theophylline likely to be of benefit in impending respiratory failure? Studies on the treatment of acute asthma in the accident and emergency department have failed to demonstrate any benefit of adding theophylline to optimal inhaled beta agonist therapy, and the EPR3 does not recommend this practice. Furthermore, several double-blind, randomized, placebo-controlled studies have demonstrated that theophylline does not add benefit to intensive therapy with inhaled beta-2 agonists and systemic corticosteroids in hospitalized adults or children who fail to respond to aggressive accident and emergency department therapy with short-acting inhaled beta-2 agonists. Note that theophylline is not recommended for routine management of hospitalized patients with asthma. Although one study has shown a slight benefit of theophylline in hospitalized adult asthmatic patients, one of the authors of that study has since noted that if adequate doses of short-acting inhaled beta-2 agonists and systemic corticosteroids are used, theophylline is probably not routinely indicated. Although further research is needed to establish whether theophylline may add benefit to hospitalized adult patients who have impending respiratory failure, routine use of theophylline in hospitalized asthmatic patients no longer is justified. Limited evidence suggests a potential benefit of theophylline for some pediatric patients in the ICU who have impending respiratory failure. However, more recent study does not show any benefit and suggests longer ICU stays and time for symptom improvement. EPR3 does not recommend the use of theophylline in the hospital. SHT's clinicians decide not to use theophylline. If a clinician decides to use theophylline in this setting, a current pharmacokinetics text should be consulted to help ensure safe and effective dosing and monitoring. SHT has continued to improve slowly during the last 72 hours. The nebulizer treatments with albuterol are now administered every 4 hours, and he is taking oral prednisone 80 mg per day in 2 divided doses. Peak expiratory flow measurements taken before and after the last albuterol treatment were 65% of predicted and 80% of predicted, respectively. So my question to you reads, is SHT's long duration of recovery unusual? The correct response is no. In a patient such as SHT, whose condition progressively deteriorated during a long period, a slow reversal should be expected. The prolonged deterioration reflects an increasing inflammatory response in the lung. These patients require prolonged, intensive bronchodilator and anti-inflammatory therapy before maximal improvement is noted in pulmonary function tests. Thus, SHT should continue to receive systemic corticosteroids for approximately 10 days after such a severe acute exacerbation of asthma. SHT has been taking corticosteroids for a total of 6 days. Long-term corticosteroid use is associated with many adverse effects, e.g., adrenal suppression, osteoporosis, or cataracts. My question to you is, what adverse effects are related to short-term corticosteroid use? Short courses of daily corticosteroids are usually associated with minor side effects. Facial flushing, appetite stimulation, gastrointestinal irritation, headache, and mood changes ranging from a mere sense of well-being to overt toxic psychosis are the most commonly encountered adverse effects of short-term corticosteroid therapy. Acne can be exacerbated in patients susceptible to this skin problem, and weight gain also can occur because of sodium and fluid retention. In addition, hyperglycemia, leukocytosis, and hyperkalemia are possible. All of these problems are transient and will disappear with time after the corticosteroids are discontinued. These short-term adverse effects are less common when small corticosteroid doses are used. However, corticosteroid doses must be adequate to prevent disease exacerbation. The minor risks of short-term use are far outweighed by the marked benefits. SHT's history of increased use of his short-acting inhaled beta-2 agonist inhaler during the early stages of this asthma attack suggests improper use of this medication. So my question to you is, what are the risks from overuse of beta-2 agonists? The overuse of short-acting inhaled beta-2 agonists as a possible risk factor for asthma death has been debated for decades. Because most deaths attributable to asthma occur outside the hospital setting before the patient can reach medical assistance, the primary cause of death in asthma most probably is an underestimation of the severity of the asthma attack by the patient and delay in seeking medical help. Overuse of quick reliever medication suggests inadequate asthma control and can lead to fatal asthma. The frequency of as-needed doses of albuterol is a good marker of the adequacy of inhaled anti-inflammatory therapy and environmental control measures. For example, if the patient needs the short-acting inhaled beta-2 agonist more than 2 or 3 times a day, the clinician should reassess environmental control, increase the dose of inhaled anti-inflammatory therapy, or add other controller agents per EPR3. Patients should be instructed verbally and in writing regarding the proper use of their inhalers during acute attacks and in recognizing when it is necessary to seek medical assistance. Patients can continue using their short-acting beta agonist inhalers on an as-needed basis until they reach medical care. SHT should be considered at high risk because of the severity of his latest attack and should be given oral corticosteroids to self-administer at the first sign of significant deterioration. In addition, SHT should have a home peak flow meter so that he can objectively determine the severity of his attacks. Finally, the beta-2 agonist controversy does not extend to use of high dosages in the acute care setting. High dosages are essential in the accident and emergency department and hospital and, as discussed previously, usually are tolerated very well. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 355.